The following podcast is part of a certified educational activity titled Sjögren's and the B-Cell Frontier, What Clinicians Need to Know Now to Prepare for Future Therapies. Access the entire activity and complete the post-test at peerview.com/FBZ860. Downloadable slides and practice aids are also available.
Hello, I'm Thomas Greaterbeck, rheumatologist and member of the Sjögren Center at Johns Hopkins University in Baltimore, Maryland. Thank you for joining this educational program to learn about the promise of B-cell targeting therapies in treating Sjögren's disease. These are our goals for today. During this presentation, we will learn that B-cell dysfunction drives Sjögren's disease. We will look at the pathophysiology and how it contributes to systemic manifestations. We will discuss comprehensive assessments, including clinical indices and patient-reported outcomes that are essential for prompt and accurate diagnosis of Sjögren's disease. And finally, we will talk about emerging B-cell therapies that show promise in overcoming current treatment limitations and improving disease management. So Sjögren's disease is a quite prevalent disease. We think that probably the rate is about 0.6 to 1%. And it's nearly as common as rheumatoid arthritis. The difficulty here is that, of course, dryness symptoms are very prominent in the general population, up to about 30% of patients, and of all kinds of patients and healthy controls, if you will, may have sicker symptoms. And so figuring out who of those patients has Sjögren's disease is not very easy. The presentation, we know it's a chronic autoimmune inflammatory disease. So it's not only a disease of dryness and fatigue, but we do have inflammatory processes that occur in different organ systems in the body as well. But it is characterized, of course, by oral and ocular dryness, which occurs in almost 100% of patients. The Sjögren's disease can occur in conjunction with other systemic autoimmune diseases, especially rheumatoid arthritis and lupus. And we know that organ involvement is quite common in about 30 to 50% of patients. There is also an increased risk of lymphoma, predominantly the B-cell type, non-Hodgkin's lymphoma. The risk is probably about 18-fold. In some population can even be as high as 40 times. And then, very importantly, recent development in the terminology. There has been a recent publication on the change of Sjögren's syndrome to Sjögren's disease. This was the Rome Consensus Statement from 2023, and we nowadays prefer the term Sjögren's disease over Sjögren's syndrome because it really denotifies that we have knowledge about specific pathways in the disease. We have specific disease patterns that we can see. We have genetic pathways that we know about. And it also really acknowledges the importance from the patient perspective, rather than saying someone has a syndrome. To actually have a disease is something that really validates the patient's standpoint as well. And that has been done in many other syndromes that have been evolving to disease over time. We also do say now Sjögren's with or without associated disease, rather than saying secondary Sjögren's, because Sjögren's is not really secondary to the other autoimmune diseases. It's a systemic autoimmune disease like the others as well. And so we want to acknowledge that patients may have both diseases with an equal footing. So understanding the patient burden. Here are some insights from the National Sjögren's Foundation survey that was published in 2022. And it really shows the broad spectrum of symptoms that patients suffer from, and that you may not necessarily have all in mind when you see a Sjögren's patient in front of you. So symptoms with major or moderate impact on quality of life. You can see on the left side, fatigue is very prominent. I would say from my clinical experience, one of the most debilitating symptoms in Sjögren's disease, but certainly dry eyes and dry mouth are also quite bothersome. Then we often see joint and other pain-related symptoms, so about 65% of patients. And then maybe on the bottom to mention brain fog is probably something you have quite frequently seen in your patients with over 50%. Sjögren's has an immense financial impact on patients, especially when it comes to dental care, for example, and other health-related treatment costs. People take a lot of time off of work, up to 42%, and almost a third may even stop working. So from a patient perspective, patients really unanimously want, they wish there were better treatments for Sjögren's disease. So let's think about a concrete example for a moment. We'll meet Becky, a 62-year-old woman who was seen by her primary care physician a few times over the past 2 years, and she is just not feeling well. She says she has noted that her eyes are dry and gritty, and she has difficulty speaking for longer periods of time because her mouth gets dry, and she does not feel that gets better. She also notices some joint pains, just feels stiff in the morning, and feels overall tired. And the primary care doctor looked at the most common things to look at: thyroid function, check the blood count, noticed a little bit of a low white blood cell count, but otherwise didn't really see much on the workup. So eventually, the primary care doctor said, maybe you need a rheumatologist. And so Becky came to the office with the symptoms that she described. And as we talked more about it, she says she has joint pains in the hands and the wrists in the morning. She has stiffness that does usually get better after about 30 minutes. She feels tired almost every day, but then sometimes she has even flares, and her fatigue gets really severe that she has to lie down and she can't really do anything. And then she noticed sometimes when she eats, she gets pain in the jaw, and it feels like there's a tightness and maybe swelling intermittently in her jaws. So that's what she initially says. And, from a rheumatologist perspective, we, of course, think about our systemic autoimmune diseases. And so we have ideas about what this patient could have. So Becky could have maybe undifferentiated connective tissue disease. She could have maybe a rheumatoid arthritis or lupus disease. But not everyone would maybe think about Sjögren's, even though the patient mentions dry eyes, dry mouth. And sometimes that is important to keep in mind. So we would probably start with some serologies as an initial workup. And we will probably do some functional testing, and we will get back to that. So here is a little bit overview of it, Sjögren's disease subsets and clinical features. And, of course, they are not separated really by columns, and they do blend into each other. But maybe to highlight, we have patients where we think they have mainly glandular involvement. And when we say it's glandular, we mainly mean the functional aspects. So maybe not having decreased saliva, having decreased tear production, and having maybe some fatigue. But overall, there is no signs that organ systems are involved. And often we see perhaps in these patients like functional deficits when we measure saliva and flow, saliva flow and tear flow, but we don't see really any abnormalities on other blood work. When we get to periepithelial lesions, that usually means there is more of a adaptive immune response type, and we may see infiltrates in the let's say salivary glands, or in pulmonary tissue or renal tissue, and we can see that especially the B cell response is getting more organized, and that could, for example, happen in bronchiolitis, in interstitial nephritis or cholangitis, for example. And then we also have autoantibody in immune complex related features. So this is usually when there is a lot of B cell activity. We get hypergammaglobulinemia, we get immune complex formation, we get, maybe germinal centers, and we talk about that a little bit later in the salivary glands. And as a consequence of that, we get more this other systemic disease phenotype. And so we see that, for example, in skin vasculitis, like cryoglobulinemic vasculitis. Cytopenias probably are predominantly mediated by antibodies. Glomerulonephritis, similar to what can happen in lupus. And arthritis, probably also immune complex mediated. So there is a spectrum of immunologic processes that kind of goes along with the clinical phenotype. So what are some of the clinical manifestations? So we have, of course, dry mouth, xerostomia, and what findings do we see? So in later stages, of course, we see a dry, parched mouth when we look inside. As you can see in the picture, the tongue may start to get really dry and even lobulated. Sometimes there's no pooling. People can get candidiasis. Most often we see candidiasis a little bit different than what you usually expect as thrush. In other immunosuppressed patients, it's not typically the whitish colored candidiasis, but it's the shiny red surface candidiasis that we can see. Patients can have parotid gland swelling and submandibular gland swelling, probably in about a quarter of patients, and they have an increased risk for calculi. And sometimes the parotitis can get over-colonized with bacteria and can lead to infections. Although most of the time we do think that when patients have flares of their parotitis, it's inflammatory, and we tend to treat that in that way as well. We can prevent some of the dental damage by early on prescribing topical 1.1% sodium fluoride toothpaste, preferentially along with calcium and phosphate to support remineralization of the teeth. How about xerophthalmia? So dry eyes can have a lot of different aspects as well. So some people will really say they have dry eyes, but other people may say they have blurry vision, or maybe they can't read a computer screen for longer. So it's important not to just think of dry eyes as a symptom, but related as well. People can have sensitivity to light, similar to what you see sometimes with migraines, UV light, especially when they're at work. There are some basic steps that you should take when a patient reports dry eyes. So thinking about the tear film assessment, as you can see on the bottom, we do have several layers, and maybe most importantly, the aqueous layer is the one that is responsible for representing the tear production as it comes out from the glands. The lipid layer on top is actually a kind of a sealing layer that prevents the tears from evaporating, and that is very important when you see a patient with dry eyes, since the lipid layer is mainly maintained by the meibomian glands, and disease of the meibomian glands can destroy or decrease this lipid layer, causing evaporative dry eye syndrome, which is very different from Sjögren's. And that's where collaboration with an ophthalmologist can be very helpful to figure out what kind of dry eye disease the patient has. We can do the Schirmer's test, the filter paper test, and we'll talk about that more, and also an ocular staining score, which is technically a little bit more difficult, and we need to probably restrict that to more specialized centers also in the future. But it's something that's part of the classification criteria and that we should be aware of. So besides those cardinal symptoms, Sjögren's can, of course, affect many other organ systems. And here you can see highlighted the most common ones, but I will maybe point out articular, so inflammatory arthritis is quite common, and it can resemble rheumatoid arthritis. It's usually not as erosive or not erosive at all. We have pulmonary involvement, which can be in about 10 to 15%, can be different interstitial lung disease patterns. It can be bronchiolar involvement as well. We have the glandular. We've already talked about that. The parotid gland and submandibular gland involvement. That's very prominent. And renal involvement with renal tubular acidosis and so forth, lymph node involvement. So you can see there is a lot of there are a lot of possibilities how a patient can present other than just with the classical symptoms. It's important to think about the classification criteria for Sjögren's for a moment. When to use future therapies may rely on populations that are defined by classification criteria, at least for the moment. And so I think it's good to review some of the cardinal features of the classification criteria and also some of the pitfalls, so you can feel confident about using the classification criteria for your patients. Importantly, we don't really use them for diagnosis. There will be other diagnostic criteria at some point in the future, but for now, these are classification criteria, so used in clinical trials and also for clinical research. So we have histologic evidence of the disease using a salivary gland biopsy. We have the anti-SSA positivity, and then we have functional tests, the ocular staining score that I mentioned earlier, the Schirmer's test to measure tear production, and unstimulated whole salivary flow. It's important that the last two can certainly be done in the office by a rheumatologist. It takes about 5 to 10 minutes, and I would expect maybe that will be done more in the future as well. And if you have a score of 4 or greater, that means you have meet criteria for Sjögren's. You have to apply some exclusion criteria, as you can see below, since some other diseases may look very similar to Sjögren's disease. So what are some of the key approaches? As for the Schirmer's, I think the most important part is to do one, and to do it right. Usually it's done without anesthesia. That's the correct way of doing it. And if you have less or equal to 5 millimeter of wetting in 5 minutes in at least one eye, you meet that classification criteria. Unstimulated salivary flow, similarly, I would say it takes 5 minutes to perform. Really, like a patient, there are good instructions available online. Patients basically spit in a cup and you measure the amount of saliva produced. And then just a couple of things about the lip biopsy. That's one of the critical parts, I think, that is not universally done correctly. So pathologists may not read the biopsy according to guidelines of how they should be read for Sjögren's disease. So in particular, we want to make sure that we have an adequate sample of about 8 to 10 millimeters square. We also we would like to see in the report the number of foci that were found and also the surface area of the tissue. And those are critical parameter at the minimum to really know that the pathologist evaluated the biopsy right. So if you don't see those parameters, it is good to go back to the pathologist and ask about if you can get more detailed information. There may be, in the future, AI may be helping us to read some of those biopsy slides, and we may be able to apply some more uniform, consistent reads in that way. So just briefly, some of the Sjögren's disease mimics and overlapping conditions. So we talked briefly about lupus, rheumatoid arthritis, and then also systemic sclerosis. So some of the more common features in those diseases can certainly also be represented by Sjögren's. And so it's important to, I would say, not forget Sjögren's as you see patients with arthralgias, maybe photosensitive skin rash, maybe interstitial lung disease, right? Because they could have Sjögren's as well. And we will find out more about pathways on a molecular level in the future, but some of these patients may really have overlapping pathways, even though we call them different diseases. So I will maybe point out, especially for systemic sclerosis, we have a subset of anti-centromere positive Sjögren's patients who really are Sjögren's and not scleroderma patients. So, when you think of centromere, you think of limited scleroderma, you think of Raynaud's and Crest syndrome. But centromere can actually be a marker of Sjögren's, like anti-Ro as well. And sometimes about half of the patients are double positive, but there are also just centromere positive patients. So it's important to also not forget about that subset. There are mimics of Sjögren's, that we know from a clinical standpoint how to separate them, but I just mentioned IgG4 disease and sarcoidosis here. So how do we measure how active a patient is? So we talked about the features of dryness and fatigue, but they're not reflected in any objective measures as far as we know so far. So we often start out with the ESSDAI, so the Euler-Sjögren Syndrome Disease Activity Index, and this is a measure. Currently, we use it in clinical trials, but it probably will find its way into clinical practice because patients may have to meet a certain disease activity to actually qualify maybe for new biologic drugs. So this slide is really for you to look through in more detail, but there are 12 domains. And each of those domains can have several subdomains, if you will. And that makes, assessing Sjögren's sometimes quite complex. But the good news here is that a given patient usually keeps the same pattern of disease manifestations over time. So even once they have symptoms for 5-10 years, if you assess them in the beginning thoroughly and you follow them, it's not so common that they will develop new domains over time. Lymphoma is, of course, one potential exception, but overall, a patient is pretty stable. So this is a good kind of template to use, even when you see a Sjögren's patient for the first time, to think about what kind of disease manifestations they could have and check off the ones that are important. And then you measure activity over time. And, we're not going into, this is not like a teaching session about how to use the ESSDAI, but just to say these domains all have different activity levels. They have different weights. And if you take the weights and the activity level and you can, multiply them and add them up, you get to a certain ESSDAI score. A medium disease activity score is considered 5 to 13, and then everything higher is considered high disease activity. And then, of course, we have lower disease activity. Now, you will notice the biological domain has a different color. So the biological domain is mainly a measurement of serological activity, so immunoglobulins, hypergammaglobulinemia, hypocomplementemia, and so forth. And so there has been another development of something called the ClinESSDAI, which is very similar to the ESSDAI, except it leaves out the biological domain and scores the other domains a little bit different, because sometimes there's concern that the biological domain may not really represent true disease, clinical disease activity, and may be influenced by some of the drugs. But both of these are used, ClinESSDAI and ESSDAI as well, in clinical trials. And then we have the patient-reported outcomes. So especially, if we think about the patient I described early on with if you have dryness and fatigue and brain fog, like how do you measure that? We don't have physiological pathways that we can really measure at this point that would tell us why a patient has these symptoms. And so we use patient-reported outcomes such as the ESSPRI, which is commonly used in clinical trials, asking about dryness, fatigue, and pain on a score from 0 to 10. And then we have the patient global activity, which kind of has more beyond that. It's the general state of the patient, which can be also done on a numerical scale or on a Likert scale. And I think this will become more important over time for also in clinical practice to measure these patient-reported outcomes, since it can show us how a patient may respond to therapies over time. So along that line, Sjögren's disease is undergoing an assessment evolution. I already mentioned Sjögren's disease is so heterogeneous, and if we put together trials, like how do we put all these different kinds of patients with all these different phenotypes in one trial and expect to have a positive outcome? So recently, there has been a development of composite measures like the STAR or CRESS, which actually take different domains into account, and people may have improvement in certain domains. And if you count it then together, that eventually, if they pass a certain threshold, that will constitute a responder. The patient will be constituted a responder. So I will show you this here. So we have the CRESS and the STAR, and both of these are really very similar. I just would focus on the domains themselves and not really how to add them up. So we have the systemic disease activity, which is measured by the ClinESTI. We also have the patient-reported symptoms, like the ESPRI. And then we have functional assessments of the tear gland and the salivary gland. For the salivary gland, there is also a component of salivary gland ultrasound, which we don't get to talk much more about today, which I think is a very valuable tool in the clinic in the future. And then finally, the serological aspect of the disease as well. So you can imagine, given the heterogeneous phenotypes in those patients, if the design of these composite assessment is right, you may be able to better identify responders to therapy. And there have been retrospective post-hoc analysis of previous failed trials, and many of them have been found positive when the new criteria were applied. So this is something to know about and to look out for in the future. Similarly, we can cluster patients also based on a combination of patient-reported outcomes and biomarkers. And for that matter, we could include other clustering domains as well. But these are some of the dominant studies that have been done in the last few years, and the one on the left by Nguyen et al. is really one that has shown how we can separate Sjögren's patients out in different subpopulations, like the B cell active disease, but they have low symptom burden. So those patients would have high immunoglobulins, maybe low complement, but they don't really feel so dry or so tired as we would expect. We have the high systemic disease activity patients that have lots of organ manifestations, and there are certain antibodies that may highlight these patients. And then we have the low systemic disease activity, but patients have high symptom burden. So fatigue, dryness, very dominant, but we don't really see much inflammation. And some of these findings have really been found in these different studies. And I look at the clinical clustering at the moment more as a kind of as a tool to find out who may be patients that really belong together. And I think there will be new cluster mechanisms that we will explore in the near future. But it's important to know about just the mechanism of how we can maybe figure out more subsets of Sjögren's patients. And this just shows you, like of the mean study that I mentioned earlier, a little bit more detail. But basically, on the top, you can see that these are the different disease activity levels in those different patient subgroups, cluster subgroups. And where you can see is that perhaps focus on the red on the top, and you can see that the high disease activity patients, as expected, have the highest orange or light red, if you will. And you can see all of those bar graphs. There are over time. So starting from year 0 to year 5, and you can see how those different disease activity levels behave in the patients over time in those subgroups. And I think the top just reflects basically what I told you about the different subgroups, but the bottom really shows you in these different subgroups that people are not they are not stagnant. Like they're not it is that they do change over time. So especially the patient acceptable symptom state of evolution gets pretty much worse in all of these groups over time, indicating that they all have high symptom burden that is not really being addressed. So as we come back to Becky, so we had talked about, she has dryness, she has arthralgia with morning stiffness, she has fatigue. We talked about the differential diagnosis in her as well. And now we examine her. We do see some chronic mouth changes. The tongue is really dry. We don't get any salivary pooling when we try to express saliva from the glands. We can't do it. We do feel tenderness in the MCPs and PIPs. And when we look at the parotid glands, it appears that they are full on both sides, and they're also tender. So we do labs. We see patient is ANA positive. She's anti-Ro positive, and also rheumatoid factor positive. So, just to think about this, maybe some clinicians may focus on the joint aspects, and they may do maybe rheumatoid factor and CCP antibody first, and it comes back high titer positive. And they may say this is a rheumatoid arthritis patient, but they may not have asked about the dryness part, and they may have maybe not even sent a Ro antibody. And so I think it's important when you see this patient that you do think this could be a Sjögren's patient with inflammatory arthritis as well. And Sjögren's patient can be anti-CCP positive as well. So we will do a Schirmer's test, right? Of course, because we think about Sjögren's, and lo and behold, Schirmer's is decreased to about 3 millimeter in 5 minutes. Unexpected, because we don't really see conjunctival injection of the patient, and we wouldn't have maybe expect that degree of tear production decrease. But that's also important to mention that patients with Sjögren's can sometimes have a neuropathy in the eye. They may not experience the symptoms as much as they should. And so they may say fine, but then when you do objective testing, you will find actually that they have marked decreased function. So she actually meets classification criteria, but from a clinical perspective, you could say, does she have RA with Sjögren's, or Sjögren's with RA, or is it just Sjögren's? Anyway, I think it's most important to think about Sjögren's in this context. So let's talk about treatment now, and especially the new treatments that have emerged at the B-cell targeted mechanisms and clinical evidence. So first, we're going to look at the pathogenesis of Sjögren's disease. What do we know about this? So we do think that early on, the target tissue, and for simplicity, let's focus on the salivary glands, where we know probably the most about. We will have an insult, and most likely this was a viral infection, maybe recurrent viral infections that damage the epithelial cells. And the epithelial cells are not simple bystanders in Sjögren's. They actually, when they get damaged, they exhibit a pro-inflammatory phenotype, meaning they may release cytokines, for example, like BAFF, also other chemokines that will attract innate immune cells. And so then you get an influx of dendritic cells, plasmacyte or dendritic cells, and these are very good at making type 1 interferon. And so you get this initial stimulation, the innate immune system comes in, and then the interferon is actually promoting, similar to lupus, is promoting the evolution of the adaptive immune response. So then we get T cells, we get B cells into the gland, and they organize, they co-stimulate each other, and the B cells start to make antibodies, including anti-Rho antibodies. We've seen that in the glands. Anti-Li antibodies can be made too, and other antibodies for that matter. And over time, this feedback mechanism becomes more organized, and the B cells become they over and over get activated, and we get the development of more organized tissue in the glands, the formation of germinal centers, and then eventually we may even get lymphoma. And so you can see on that slide from this initial insult to the really very specialized immune activation that can go all the way through in any given patient. So what are the targets that we currently investigate in regards to B cell therapy? So here you can see on the left side, we have the influx of the B cells into the target tissue. And we have the T cells on the other side. And, as we said about like when they work together, we can get even lymphoma. And so how can we block this B cell activation? So we have two drugs, the efgartigimod and the nipocalimab, that are in phase 3 trials. These actually block neonatal FC receptors. So what that means is usually when immunoglobulins get taken up by cells, and this can be endothelial cells most commonly, but also epithelial cells like in the salivary gland, we get the neonatal FC receptors recognize them, pull them inside the cells, and then spit them out again. If you block that pathway, then actually the antibodies get degraded. And so you can imagine if you get the autoantibodies that are floating around in the bloodstream, for example, they get taken up and then they get digested. So you get a decrease of immunoglobulins. On the right side, you can see there's several ways of blocking the B cell T cell interaction by, for example, CD40 ligand. There are two drugs that have been studied in Sjögren's, iscalimab and dasodalibep. The later one is now in phase 3 trial. We also can block the activation of B cells. So on the top right, we have B cell activating factors. So that's the BAFF and then also APRIL. And those are two cytokines that really can activate B cells through different pathways. And we have telitacicept that can block BAFF and APRIL by mimicking a TACI receptor from the B cell, and then having it a decoy, basically have an FC receptor on the other side, and taking up all those cytokines and blocking them. And then we have ianalumab as a BAFF receptor antibody that specifically blocks the interaction between BAFF and BAFF receptor, but also actually can deplete B cells. And we will talk about that a little bit more. And then we have other molecules that are in phase 3, in particular deucravacitinib, which can intracellular inhibit activation of TYK2 and the JAK-STAT interaction. So we do not have any FDA-approved therapies for Sjögren's to date. Rituximab and belimumab have been studied in the past with mixed results. Given the pathophysiology I just mentioned, it made sense to study these two drugs in detail. The TIERS and TRACTIS studies did not meet their primary endpoints. I should mention that at the time, we did not really focus yet on ESTI and inclusion criteria as strictly as we do now. And part of that may have contributed to the trials being negative, but overall, the meta-analysis and the pool data did not show any reduction in the patient-reported outcomes that have been the primary endpoint for these studies. And then belimumab showed some interesting positive findings, but the initial one was just an open label trial where 60% achieved the primary outcome, but there was not a real control group in that sense. It was never like placebo-controlled, double-blinded. And then the more recently, the sequential belimumab rituximab trial did actually show some encouraging result with a greater ESTI reduction and B cell depletion in the salivary glands. So I think it does highlight that there is a role for B cells, and as the positive trials, phase 3 trials that we talk about next, come along, we will see that that we can really get some very encouraging results. So these are the systemic therapies under investigation. The first two, the ianalumab, the anti-BAFF receptor antibody, and the telitacicept, they have been now reported as positive in a phase 3 readout, and we'll talk about those more in detail. The other ones have had, for the most part, positive phase 2 trials, except a couple ones, and many of them are going into phase 3 studies, especially to mention dasodalimab as a CD40 blocker, nipocalimab, efgartigimod, and deucravacitinib. So we'll focus on ianalumab and telitacicept next, since they've been reported as positive phase 3 trials. So ianalumab is a fully human IgG1 monoclonal antibody with a dual mechanism of action. It very rapidly depletes B cells, circulating and tissue-infiltrated B cells via enhanced antibody-dependent cytotoxicity. So the antibody will bind to BAFF receptor and then link to NK cells, and the NK cells will then deplete the B cells. And in addition to that, we have the BAFF receptor blockade, which inhibits B cell activation and survival through BAFF receptor inhibition. So these are some of the phase 2b trials, just as a refresher, where in a dose-dependent manner, we could see a decrease of SDI over time in the patient population versus the control population. Especially if you look at the diagram on the top right, you can see that the placebo controlled in orange has a decrease of SDI of about 4.6, and then the higher dose of ianalumab 50 and 300 are lower than that. It's important to note that two things. The overall dose response was statistically significant, but each individual dose was actually not significant in this phase 2b trial. And on the bottom, you can see another characteristics of that we often see in Sjögren's trials. The placebo response overall has been quite high. So you can see 61% had an SDI responder rate, meaning they improved by 3 or more on the SDI. And then that goes up to 89% with the 300 milligram dose. So it just highlights some of the overall difficulty with high placebos, and that's pretty uniform across all of the studies. Patient-reported outcomes, there was a signal for increased stimulated salivary flow, especially in the 300 milligram dose with the ianalumab. The patient-reported outcomes did not change as much over time compared to placebo. There was a nominal effect in several time points. So then moving on to the Neptunus 1 and 2 phase 3 trials that have just been reported positive. Basically, Neptunus 1 and Neptunus 2 were 52-week studies, and they were designed very similar. The Neptunus 2 had an additional arm of subcutaneous ianalumab every 3 months instead of every month. But the other two arms were the same, so placebo received monthly injections. Ianalumab was given on a monthly basis subcutaneous to the other group, and they were randomized 1-to-1 or 1-to-1-to-1. The patient population were adults with moderate to high Sjögren's disease activity, so an SDI of 5 or greater. All arms could continue concomitant background therapy at the investigator's discretion. There were, of course, exclusion criteria in terms of certain prior biologic therapy, other immunosuppressants that were considered too strong to be part of the trial, but overall very consistent with what other trials have done as well. Patients that completed both the 52-week studies were eligible to continue in the extension trial for up to 2 years that is still going on. So the primary endpoint was the SDI change from baseline at week 48, and then there were a number of key secondary endpoints, including the SDI response, this time measured as greater than 5-point reduction from baseline, and then the low systemic disease, which means an SDI of less than 5, physician, patient-reported outcomes, stimulated salivary flow, and then safety and tolerability. So here you can see in both trials, ianalumab met the primary endpoint at week 48, and for that matter, also at week 52 remained positive. The curves between placebo and a drug separated out over time, which is starting as early as 4 weeks. And you can see the every 3-month dose on the Neptunus 2 is kind of in the middle between placebo and monthly dose. And overall, to summarize the trial, there were not really significant effects compared to placebo found in the every 3-month dose. But in the monthly dose, we could see a significant improvement of SDI, and we could also see a number of nominal statistical improvements in the studies. Most importantly, the patient global assessment and the physician global assessment in Neptunus 1 were both nominal significant positive, and that really points towards an effect just past the systemic disease activity, especially the patient global assessment. There was also a signal that ianalumab may improve salivary function. So when all the patients were pooled together and the median of baseline stimulated salivary flow was calculated, it was found to be 0.4 cc's per minute. Now, when we looked in the population above 0.4 and below 0.4, it was found that patients that had less decreased salivary flow at baseline, they actually improved their salivary flow. And in a post hoc analysis, that actually that went along with improvement of patient-reported outcomes of oral dryness as well. So this is all to say that there may be a positive effect on salivary flow, and I think we do need further studies to really figure that out. But it is similar to what was found in the phase 2b trial as well. And the safety profile overall has been favorable. There were no signals. There were no excessive infections in the ianalumab groups. So from a safety perspective, I think this is very acceptable. So the other one is the telitacicept, so a recombinant fusion protein. With a mechanism of action, it inhibits the B cell activation and survival through blockade of BAFF and APRIL, which are the key cytokines involved in B cell maturation, differentiation, and also antibody production. This is the phase 2 data. This was a rather small study compared to the ianalumab study. There were only about 14 patients in each group, so the confidence intervals are quite wide. On the left side, you can see the mean SDI over time in the placebo group. It stays relatively flat, and this is actually a signal that's quite unique to the telitacicept trials, also the phase 3 that we'll look in a moment, that the placebo response was really not there. And this is different compared to most other clinical trials where we see quite strong placebo response, usually of a decrease of SDI of 4 or more. And then you can see an SDI reduction in the telitacicept group. Interestingly, in this one, the 240 milligram group was overlapping with placebo, and the 160 milligram group proved more effective. On the right side, you can see some initial readouts for fatigue, and there is a little bit of a signal of fatigue improvement in that in the disease groups, the fatigue goes down versus in the placebo group, it stays constant. But again, this was a very small trial. Now, in the phase 3 trial, the lessons from the phase 2, the group started with 160 milligram, also had another dose of 80 milligram, and then placebo randomized 1:1:1. Similarly, also high moderate disease activity with the SDI greater than or equal 5. This was all SSA positive patients. In the ianalumab trial, there were a small group of seronegative patients involved, but that was only 6%. And then after the first 24 weeks, the non-responders in the placebo groups were randomized 1:1 to 160 milligrams of telitacicept and 80 milligrams of telitacicept. The primary efficacy endpoint, again, was very similar. SDI changed from baseline at this time at week 24 compared to the ianalumab at week 48. And then key secondary endpoints were also very similar, with the SDI reduction only being 3 from baseline to indicate response rather than 5. So here's the data. And again, what you can see, the placebo group stays relatively flat. And that's, again, it's a very unique study result, I would say, compared to all the other trials. But you can see a dose-dependent effect of decrease in SDI in the 80 milligram groups to minus 3.2, and then in the 160 milligrams to minus 4.6. Similarly, secondary endpoints, the greater than equal 3-point reduction in SDI was statistically significant in the 160 milligram group. And then the proportion of low disease activity patients compared to placebo was also highly statistically significant. Now, again, for this mainly comes out because the placebo response was so flat. And this study was done in China versus ianalumab was a global study. So we will see what the global trial with telitacicept will show. I would say from a safety profile, very similar to ianalumab, no real safety signals. I would say the injection site reactions in the telitacicept group were quite high at 40%. Versus placebo, but for the most part, this did not have any impact on the study. So going back to our patient that we talked earlier, so would we maybe consider a B-cell therapy for this patient with with fatigue, with dry mouth, with joint pains, inflammatory arthritis, and then also parotid gland swelling that comes and goes? I think you could make an argument that probably you would maybe try a different agent first. Let's say hydroxychloroquine for joint pain, for the mild inflammatory arthritis. Likely, in our experience, that does not usually have an effect on recurrent parotid gland swelling or necessarily fatigue. Sometimes it can help. So we would probably start out with something more mild, but especially if the parotid gland swelling would become more of an issue, we usually rescue that with steroids for a few days. We may consider B-cell therapy, which is quite effective, usually for glandular swelling. Now, from the phase 3 trials, we don't really know yet which patients would benefit most from these drugs in terms of SDI subsets. But I think future studies will show that. And as a guide, we can think about patients that we have positive experience with B-cell therapy in Sjögren's off-label so far. Some of the other emerging therapies, so dazodalibep, I mentioned nipocalimab and efgartigimod as FC receptor, neonatal FC receptor blockers, and then deucravacitinib as a TYK2 inhibitors. Those are all still going on. So CD40 blockade in Sjögren's, we have data from several drugs from phase 2 trials. Frexalimab failed phase 2, but iscalimab and dazodalibep were positive in the phase 2. And they have overall shown similar results, but iscalimab wasn't moved forward to a phase 3 due to potentially some unfavorable risk-benefit profile signals. But dazodalibep is moving forward. It's currently in phase 3, and I think will read out by 2027. On the right side, you can see how dazodalibep 1500 milligrams in the high disease activity group, in the moderate to high disease activity group, showed significant improvement of SDI compared to placebo. Again, here you can see a typical placebo response of about 4 or 5, sometimes in the trials, but more so in the treatment group. Neonatal FC receptor blockade. Similarly, we have nipocalimab on the left, and then we have efgartigimod on the right. We can see the ClinSDI significantly improving in the nipocalimab dose. Again, this was patients with moderate to high disease activity. This was measured by ClinSDI without the biological domain, and you can see in blue how nipocalimab at 15 milligram per kilogram, this was intravenously, showed significant improvement of the SDI compared to placebo, and a lower dose of nipocalimab over 24 weeks. On the right side, you can see efgartigimod with one of the new composite measures in phase 2, the CRESS, showing significant response of the CRESS composite index in efgartigimod compared to placebo control. And I think this is a very encouraging signal overall to use composite outcomes in Sjögren's disease. TYK2 inhibition, so we have deucravacitinib also in a phase 3 trial. Interestingly, there was not a phase 2 trial in Sjögren's disease, but there was a phase 2 trial in lupus in patients that were Rho positive, and that was positive. The result was positive, and so the drug has been taken into phase 3 now, and is also going to read out probably by sometime in late 2026. So we will learn more about that soon. Earlier, there was the CD8086, CD28 co-stimulation blockade with batacept that did not meet primary clinical endpoints. They did observe some biologic signals. The salivary gland histopathology improved. Some of the serological outcome measures improved, but it did not lead to significant improvement of the SDI. So it's currently not a medication that is used for Sjögren's. But I will say sometimes off-label in patients with inflammatory arthritis, it is something certainly to consider. So how do we prepare to integrate the B-cell therapies into patient-centered Sjögren's disease management? So let's think about one other patient, Lisa. And Lisa is already known to us. She has a 10-year history of Sjögren's. She presents for follow-up visit, and her disease phenotype is a little bit different. She also has significant dryness symptoms, dry eyes, dry mouth, dry skin. She, though, has skin vasculitis. She has recurrent palpable purpura. She has cryoglobulins, and she also has interstitial lung disease, and she has a moderate decrease in her pulmonary function test. But overall, she has been quite stable over the past 6 months. However, her weight has slowly been going down. We have looked at different possible etiologies, ruled out malignancies, other thyroid disease, and so forth. And we're starting to think, could this be maybe contributable to Sjögren's? And we know that one of the constitutional domain has unintentional weight loss as part of the scoring. So she's currently on rituximab, and overall, she's managing, she's stable. But the question now is this someone maybe we should consider one of the new B-cell therapies for this patient? So we will talk about that a little bit more in detail in the next slide, but just a food of thought from what you've learned so far. Would you consider this therapy? So what are some of the general principle managements? The treatment is typically tailored depending on symptom severity and response to therapy. So everyone should receive non-pharmacological interventions, self-care education, diet counseling, smoking cessation, preventive care, and immunization, pregnancy counseling, and so forth. Sicker symptoms are mainly topical therapies. We don't at this point really use systemic therapies unless a last resort. Routine dental care is critical, especially prophylactic therapy. So high potency fluoride toothpaste early on, other methodologies like using xylitol to prevent dental damage, very important. And then treating systemic disease with appropriate immunosuppressive therapies. And as we said, there's currently no FDA-approved therapies in Sjögren's. So I already mentioned some of these. Topical fluoride, very important. We also, for the oral management, want to increase saliva with xylitol gum lozenges. And then it's very important not to forget sialogogues or secretagogues like cevimeline and pilocarpine, which can stimulate the glands to put out more salivary saliva over time. I usually try this for 1 to 2 months. And if patients do not have a response, I switch from one drug to the other. This is guidance on ocular management. Besides the non-pharmacological, I think it's very important to be aware that there are quite a few therapies that we have available for dry eye disease, starting with preservative-free artificial tears in particular. We can then also go to serum tears, which are very well liked by the patients. However, they are not typically covered by insurance. So that is sometimes a problem for individual patients. Topical immunosuppressants. We have a wider portfolio now, which is includes, of course, topical cyclosporin in different concentrations. We also have lifitegrast, and we have varenicline. So there are more different drug classes available to treat dry eye disease. Finally, we can use scleral lenses that are usually also very effective of treating dry eye disease. However, they are also often cost prohibitive for patients. Now, if there is a meibomian gland component to the dryness, that sometimes is treated with other modalities such as warm compresses, massage, topical antibiotics or systemic antibiotics, and also procedures that express the meibomian glands and open them up. So that's why it's also important to have the ophthalmologist involved in treatment decisions. Systemic manifestations, I think this slide hopefully will be much more comprehensive in the future. I would say for inflammatory joint disease, which is one of the most common systemic manifestations, we would approach it similarly to what we do in rheumatoid arthritis, starting with hydroxychloroquine, methotrexate, combination therapy, sulfasalazine, azathioprine, all medications that are plausible. And we also will use, if the inflammatory joint disease is not well controlled, we will use biologics. And in particular, B-cell targeted therapy can be effective, like rituximab off-label, of course. We have been quite successful if there are other systemic symptoms in particular. Fatigue, typically we do not treat with immunosuppressants. We all probably know that patients may respond to hydroxychloroquine. Sometimes I would say it's probably 10% or less, but everyone should be encouraged to exercise. Acupuncture can also be tried. Gluten-free diets is something that we recommend with high benefit risk ratio. DHEA, other biologics are not really recommended at this point. I think we do need to find out more about specific results from the recent clinical trials. So in applying evidence in practice, identifying the ideal candidate for B-cell targeting therapies, if we think about who is the patient who should get B-cell therapy, I think at this point we definitely would want to target a patient with at least moderate disease activity on the SDI, so an SDI of 5. I would say sometimes maybe if they have really recurrent glandular involvement of severe parotid swelling that's very painful and requires frequent steroids, those patients, they may end up with perhaps with an SDI of 4, but that would be still maybe someone I would consider. And of course, the drug has to be safe. We have to put it together with comorbidities, other immunosuppressive states. Can they access the drug? That's going to be very important for the new treatments. Biologics usually given as injections or infusions. So is the patient, of course, okay with going to an infusion center or to self-inject at home? Those are all questions that we need to address. So for Lisa, who's our patient with the vasculitis and also the interstitial lung disease, she's on rituximab and she's managing, but there may be she's not really making progress, and maybe in some directions she's making she's regressing a little bit. So would this be someone, for example, we could imagine one of the new B-cell therapies to instead of rituximab? So I think we have, given that we have cryoglobulinic vasculitis and we know that B-cell therapy works quite well, I would be comfortable from that standpoint. Interstitial lung disease, we have some encouraging data on rituximab in interstitial lung disease in general. So concluding that this may be a good next step for this patient is plausible. We want to, of course, monitor the safety of the drug, and we want to really closely monitor the response. So, anything from not just from the pulmonary standpoint in terms of lung function tests and imaging, but also asking the patient about, of course, fatigue, dryness, and general well-being. But I think this would be a patient I could imagine maybe a different B-cell therapy, especially since she partially responded to rituximab, and we earlier looked at the rituximab plus belimumab data. So it's something that I would certainly consider. So what are the key takeaways? Sjögren's disease imposes a significant physical, emotional, and functional burden on patients. The early recognition is key to improving outcomes. We learned that B-cell dysregulation and BAFF signaling are central to the pathogenesis and also treatment innovation. Emerging B-cell targeted therapies offer new opportunities to modify disease and restore quality of life. But it is very important that we pursue collaborative patient-centered care to optimize the diagnosis and treatment across specialties. So that brings us to the end of our discussion for today. I hope you found the activity informative and useful to your practice, and encourage you to access additional program materials, including downloadable slides and practice aids. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by Boston University. This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/FBZ860.